Welcome, friends. It is our great pleasure to introduce you to SICOT-PIONEER. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Right. A very good morning, good afternoon, and good evening, ladies and gents. I'm VIKAS KHANDUJA, consultant orthopedic surgeon in Cambridge and also the president-elect for SICOT. It's my great pleasure to introduce the webinar today. Got the czars of revision knee arthroplasty presenting today, and I'm ever so grateful to Dr. Mujib and to Dr. Rajgopal for selecting fantastic faculty to actually present on the webinar. SICOT-PIONEER continues to grow, and with this event, we would have done over 78 events, and the number of views has crossed over 100,000. So big thank you to all the viewers from around the world. Do keep following us, and the fanfare of SICOT-PIONEER is over 8,000 members in there now. So without much further ado, I'm going to hand over to our two moderators, Dr. Mujib, who's a consultant orthopedic surgeon in Johns Hopkins Hospital and an adjunct assistant professor in Saudi Arabia, and also to Dr. Ashok Rajgopal, who doesn't need any introduction, the big czar of knee surgery over Asia Pacific at the Medanta Hospital and the director there as well. And I'll let them introduce the excellent faculty to you in a minute. Over to you, Mujib and Ashok. Thank you very much indeed to all the faculty as well.
Thank you, Vikas, and thank you, panelists, and I welcome all the participants to this wonderful session. This is our first revision session in relation to a total knee replacement. I'd like to thank and welcome my co-moderator, my good friend Mujib MANZARY. We have an excellent faculty that are going to present on several topics of revision. This is the first of two such sessions. I'd like to welcome, first of all, Dr. Rajkumar Thangaraj, who is a consultant orthopedic surgeon in Inverness. And he's going to talk to us about the most fundamental aspect of revisions. Why do knees fail in total knee replacement? Raj,
thank you. Thank you for inviting Dr. Rajgopal and Vikas. I'm just gonna share my screen now for presentation. I presume you can see everything now. Yeah. Right. So thank you for inviting. This is the first part of the Revision Total Knee Replacement live webinar. Thank you for the invitation. My talk is on why do knees fail. I'm based at Rajkumar Hospital in Inverness, Highlands in Scotland. So my talks is based on 4 topics, essentially introduction, factors, common reasons, and learning points. We know that we are doing more than 1 million per year at the moment, and we are expecting this to keep on rising. If you put it in Google, it straight away says that there is almost up to 20% of patients are not satisfied with the results of the procedure. And if you look at the PubMed, you can see the number of publications, the revision knee replacement is going higher and higher, signifying the importance of the failure mechanisms to be understood by the operating surgeon. This is the NJR data from 2023. Since the data has been collected and published, so far 1.5 million knee replacement been done, out of which almost 1.3 million has been on cemented knee replacement. Now, going on to the factors for failure, I call it as 3 factors, essentially: surgeon factors, implant factors, and patient factors. Going into the surgeon factors, we know that the key factor is experience. As you keep on doing over the years, you become more experienced. You know your anatomy very well. You'll know how the components are placed, especially the rotational femoral component and the tibial component. So we know that there is a bit of a higher risk of failure when you're starting and as a trainee surgeon. So essentially, what it leads is when you're slightly prone for component malalignment, as well as certain times intraoperative fracture. And finally, things can happen like MCL injury or patellar tendon injury if you're not looking after a soft tissue and protecting it well. Moving on to implant factors, this is always a little bit of a debate around it, whether it's a fixation issue, cemented versus uncemented, or versus hybrid fixation, which is better. We know that in the hips at the moment, the drive is between, all 3 fixations are working pretty good, especially the hybrids. And then from the design point of view, cruciate retaining versus posterior stabilized components, and constrained versus unconstrained, and again, bearing surfaces problem, which is mobile versus fixed bearing. Looking into our NJ data this year, you can see the survivalship that the cemented cruciate retaining fixed bearing shows a much lower revision rate. The only other component that matches that is a monoblock tibia, whereas the mobile bearings as well as posterior stabilized have got a slightly higher rate of revision, and as well as constrained components, when they're used, they have a higher rate of revisions. Just for example, a bilateral mobile bearing, 5-6 years down the line, yearly loosening, we don't know real happening. One assumption is the mobile bearing causes too much of stress to be transmitted towards the components, and causes the component loosening. Again, a post PS also can cause more weight stress driven into the posterior condyles if the flexion gap is too tight, can cause early failure as well. And one other causes of early failure is if there is an early complication in terms of infection or a knee replacement, if it has to be revised within the first year, the chance of re-revisions goes significantly higher. This is again taken from the NJR, where it can see that if a revision happens after 5 years after this index procedure, the revision rate is much lower. Moving on, the patient factors, again, age and sex seems to be a factor. We know that younger male patients, when they have a knee replacement less than 55 years, they have a higher revision rate due to the high demand, whereas if a patient is more than 70 years, their revision rate is much lower. And among the sex, in the same cohort, a female seems to have much lesser revision rate compared to the males. There has been a lot of discussion regarding the high BMI, but this has been put into question recent years. And then whether the indication is for primary versus secondary osteoarthritis due to rheumatoid arthritis or any seronegative arthritis, because the disease pattern is different, as these patients have got other comorbidities, including being on immunomodulators as well as other previous surgeries in the knee. Systemic medical issues also need to be taken into consideration, including diabetes, rheumatoid arthritis, and the soft tissue status, especially peripheral vascular disease, seems to affect the outcome as well. Now, moving on to the most common reasons for revision knee replacement. There are multiple reasons, but most common causes for failure is aseptic loosening or osteolysis. The aseptic loosening is predominantly a failure in the fixation, and this can be due to multiple reasons. Traditionally speaking, we speak about the polywear as a cause of aseptic loosening, but around the knee, if the forces are not being balanced or if there's a significant tightness in the flexion or extension gap, that can rattle the components as well. So looking at their data in the UK from England, it seems that the aseptic loosening is the most common cause, with the overall cause of 35% as a cause of revision, out of which most single stage revisions, 45% are due to aseptic loosening. The aseptic loosening sometimes mimics an infection, but when we open it up, it does eat into the bone with severe osteolysis, like in this particular case, where the condyles are quite damaged. Moving on to the next common cause, it's the prosthetic joint infection, which is a real nightmare for any arthroplasty surgeon. We stick on to the European Bone and Joint Infection Society's 2021 definition, where infection can be divided into 3 groups, and we treat it accordingly. But the infection can be both acute, subacute, and chronic infection, and could be due to single and multiple organism. The biggest problem in PJAs is difficulty in diagnosis, and culture negative PJA is another problem in the years to come by. And we feel that over the years to come by, prosthetic joint infection may be the first cause of revision than aseptic loosening over the years. At the moment, it is about 27%, but we expect it to rise over the years. Moving on to the other common causes, instability due to ligamentous injury or later trauma to the knee, causing a component malalignment, is coming at 14%. But very often the instability is due to both polywear and instability, and that comes around 12% of incidents. Now, when we speak about all these incidents, this is in the England data, but I'm afraid the overall data around the world can be completely different, and there may be multiple variables that has to be taken into account. Periprosthetic fracture is on a rise, especially in Western world, and we feel that more cases of periprosthetic fractures are being fixed, so that they are not coming into the NGR data to look at as a revision cause, as most of them, we feel that probably 30 to 40% are getting fixed rather than replaced. And then final causes, malalignment, unexplained pain and stiffness come around 4%. This could be either a cause of early revision or could be as a late revision. But in the future, I feel that the combination factors are the commonest reasons for revisions. For example, in this case, it's a loosening and instability is the indication. Loosening and fracture of the components is going to be a problem in the future. But the most worrying thing is infection, periprosthetic fracture can happen at the same time, like in this particular scenario, immediate post-op injury causing wound problems and infection and the periprosthetic fracture. In a very elderly people, we are having people living into their 90s and they are having wear, loosening, instability and periprosthetic fractures causing a reason of revision. And then there are unknown factors. We know that the robotics are in a rise. We don't know that it's going to be a factor. All the logbooks, we know that we have to tick a box if we are doing robotics as well. So coming to the end of my talk, I hope I've been within my time. The learning points are aseptic loosening, PJA, and periprosthetic fracture are the common reasons for knee failure. Young patients, high demand patients, and early revisions are associated with a higher rate of revision. And please consider surgeon, implant, and the patient factors. Thank you.
Thank you very much, Dr. Rajkumar. Our next speaker is Professor Nicolaas Budhiparama from Indonesia. He's the founder of Indonesian Hip and Knee Surgery Association, as well as Professor of Orthopedic Surgery at Erlangen University in Indonesia, as well as in Leiden University Medical Center in Netherlands. He'll be talking about preoperative planning for revision total knee arthroplasty.
Thank you, Majib. Today, I would like to talk on preoperative planning for the revisions total knee replacements. This is my disclosure. So when we talk on surgical planning, you have to understand of implant design using the primary and technical principle of the procedures, that is restoration of natural mechanical alignment, preservation of the joint line, restoration of a coronal sagittal balance, maintenance of pattern tracking, up to restoration of the posterior tibial slope. So it's very important to know your basic, is that know your tools, evaluate the bones loss, and evaluate the ligaments. And when you talk on preoperative planning, you have to know what kind of surgical exposure you'd like to do, and how to remove the implant, balance inflection extensions, and manage the bone loss up to secure fixations. Very important is what is being said by Ray, is the identified mode of failures, rule out of infections, and avoid delays. So when you look at the radiographic, look at the bone deficiency, whether it's contained defect with an intact bony rim or uncontained defect, there's no peripheral support for the implant. So I start with surgical exposure and implant removal. It's the most essential part of the revision, are avoid wound necrosis, protect the extensor mechanism, facilitate implant removal, accurate implantation of revision components, and appropriate balance of the soft tissue. So I start with the skin incision. I use the anterior medial incision. Try to use the primary etiquette incisions. In case of multiple incision, then use the most lateral or Shyam's incisions. And we have to mastering the extensile exposure, especially in patients with difficulty everting patella, flexes less than 110. So we have to mastering the extent capsulectomy. You have to know how to do the tubercle osteotomy up to medial epicondylar osteotomy. Remove implant with the least possible damage to the supporting bones and ligament. So this all equipment you must have it: the osteotome, the giggly saws, the high-speed bus, and the extractors. Tibial component removal sometimes will be difficult. So what you have to do is the tibial tubercle osteotomy. They will improve the exposure and give access to the tibial stem. So in principle, the removal of the implant is adequate exposure. Remove only what you need, unless it's an infection. You have a variety of tools and loosen before extractions. But the very important is be patient. So now we'll move forward for the management of the bone defect. So I'll use that ALRI classification. Why is it important to address? Because rationale is that we have to restore anatomic joint line, optimize ligament stability, and minimize the need for more constraints implant. The options are, we can put a cement, or you can do an implant with mother augment, structure, allograft, or a metal sleeve or cones. So this very important quote from Charlie Eng, that the surgeon should anticipate the worst scenario, because often the defects turn out to be more severe than the predicted from the radiograph. I think to manage the management strategy of the bone defect, this matrix of bone loss filling is very important. As you can see here, if this defect is very small, you can fill with the bone graft or cement. If it's bigger, then you can use the metal augments up to structural allograft or megas prosthesis. So very important to consider that the femur controls the soft tissue, and the extensions gap, as you can see here, the distal femur decide the position, while the flexus gap will be by the posterior femur. And for me, when I perform this revision, it's very important is to establishing the tibia as the foundation is the key in revision. It's based to build the rest of the revision procedures, and tibia recut perpendicular to its long axis. So this algorithm from my friend here, Go Chin Lee, I think it is very helpful. Then he divided in three categories. One is not too bad, and you can fill with cement or modelized graph. In case of a real bad, you can you can reconstruct with a structure, allograft or augment up to custom or hinge or tumor prosthesis. So I will start the method of treatments that in group A1 is cement, or you can fill cement and screw enforcement or metal augments. And the question now, are short cemented stems sufficient to achieve stable tibial fixations in case of moderate bone loss? So in this kind of cases, do you need a long stem? And this publication from Mayo is very helpful. They said there's no significant differences in overall stability profile and on short cemented stem with cone. Nowadays we have a cone versus long press fit stem without cones. So I go forward with the first cones. That cones are preferred options for extensive bony lesions of defect type RE2B or 3. And is allowed to achieve rapid bony ingrowth with potential for long-term biological fixations. While metaphyseal sleeve, it is metaphyseal now becoming gained popularity. That is due to the possibility of acting as an intermediary cutting guide. But sleeve cannot be customized with a burr and cannot be used in more severe uncontained defects. So the guideline, I think this is very important to judge your preoperative planning. What are you going to reconstruct? This is from Faris Haddad and et al. That is a simple reproducible framework for planning, assessing femoral tibial bone stock and defects, and plan implant selections. So he divided into three, the zone 1, zone 2, and 3, epiphysis, metaphysis, diaphysis. The most important thing to have a stable reconstruction is gain fixation at least 2 zones. How about the degree of constraint? Use the less as possible. But constraint is often unnecessary if joint line restoration in a proper component position is achieved. The classic quotes that choose the lowest constraint. But it's not always true, because even with constraint, the revision rate is not higher. So the indication is the complete collateral ligament incompetence, severe bone loss beyond the epicondyles, and flexus gap larger than extensions gap. So I quote this from Matthew Cray. He said, be aware of persistent pain, because revisions for pain of unknown etiology, as being said just now, will be disappointing. So my take-home messages are, each treatment decisions must be individualized, pertaining which implant to use, how to achieve stability, and how to reconstruct the lost bone. Surgeons must be familiar with individual implant system and their limitation. Appropriate classification system is helpful for surgeons to determine the treatment options. Thank you very much for your attention.
Thank you, Nico. An excellent presentation on preoperative planning. Now, our next speaker is Dr. Louis Chan from Hong Kong, and he's going to talk to us on exposure in revision total knee replacement. Louis, all yours.
So thank you, Ashok, for the introductions. So today I'm going to talk about exposure in revision total knee. So this is my algorithm in revision total knee. I go through this list in every of my revision case. There are a lot of important points, but today I'm going to concentrate on the surgical exposure. Why surgical exposure is important? Because with good exposure, you can only have good visualizations for safe component removal and then accurate reimplantations. More importantly, it's also important to avoid damage to the skin and extensor mechanisms. So before talking about the exposure, let's review the basic anatomy, especially the blood supply to the anterior skin. The principal blood supply to skin is from the medial side, that is the saphenous artery, to major contribute to the fascial plexus. That's the reasons when there is a multiple longitudinal scar over anterior knee, you should choose the most natural scar for your incisions. It's also important to know the blood supply to skin in front of the knee is from the vascular plexus, just superficial to the fascia. To avoid cutting the blood supply from the plexus to the skin, you should choose the right depth for skin flap elevations. You should have a full thickness skin flap elevations in continuity with fascia. Old staying still hold shoes. Prevention is better than cure. If you don't respect the blood supply, it will result in whole full thickness soft tissue necrosis as shown here. When there is a multiple scar, you should consider the age of scar and the direction of scar. Old scars, say more than 20 years old, you can safely ignore it as the subdermal plexus has enough time for revascularizations. For longitudinal scar, you can make for transverse scar, you can safely make a longitudinal scar. For multiple longitudinal scar, you should have a minimal skin pitch greater than 6 cm. For difficult case, you should have a preoperative consultations. The option 1 is a one-stage surgery, that is arthroplasty for plus flap surgery, just like the medial gastric flap in the same surgical setting. In a real difficult situation, you should consider 2-stage surgery, that is flap first. Once flap is stable, then proceed with arthroplasty. There new advance in the wound management in revision knee settings. Recent journals suggest close incisional negative pressure dressing can decrease wound complications and SSI in revision knee setting. And that is also one of my journal also confirmed that. So therefore, the dressing choice in revision knee setting in my routine case would be negative pressure dressing. For surgical exposure, the workhorse still the medial power patellar approach. I think after opening the aphotomy, most important is to have sequential scar release. That is to release a scar from the suprapatellar pouch, lateral and medial guttus, peripatellar tendons to release a scar, so as to feed the extensor mechanism for the scar tightening. In difficult exposure, don't insist everting the patella, just subluxate the patella, so as to avoid tensions on the extensor mechanisms. An article from Rush University actually showed that most surgical exposure in revision knee can be achieved with medial power patellar approach with scar release. There's no need for extensor exposure. But in really difficult case, you should consider extensor exposure. First is the rectus dip, as shown here, advocated by insole, a 45-degree oblique incision at the proximal end of the quadriceps tendon to facilitate the exposure. This is also my preferred technique in difficult case because it can allow the patients follow the usual rehab, allow free knee mobilization post-op, not associated with extension net. TTO, that is the tibial tuberosity osteotomy, is another technique popularized by Professor Neil Whiteside. Osteotomy of length around 6 cm, including the tibial tuberosity, is made in coronal plane from medial to lateral. Don't saw through to lateral, keeping the blood supply from the osteoperiosteal hinge laterally. In the end, fixations of the TT fragment with wire or screw. For completeness, I need to mention the rewired quadriceps tendon. It is rarely used right now because it damages the quadriceps tendon, devascularize the patella, and it can potentially result in extension net. I only use once in my career right now. This is a case I need to use a quadriceps tendon because of significant scar tissue in the revisions, and the patients have actually no knee fashion at all. So I need to have a quadriceps rewired tendon in order to increase the length of the extensor tendon. So last but not least, I need to mention one of the technique probably that is really known by the others. This is banana peel, as advocated by Professor Aaron Hoffman. This technique involving peeling the patellar tendon as a complete sleeve of the tibia, leaving the extensor mechanism intact with a lateral hinge of soft tissue. Because of this technique is very user-friendly, right now this is my first choice in the extensor exposure. So, and I have the following conclusions. Surgical exposure, the important takeaway, you need to know and respect the blood supply to the anterior knee, need to know the anatomy. The workhorse in the revision case still the medial power patellar approach with sequential scar release. In really difficult case, you need to consider different extensor exposure, vertex dip, banana peel, TTO, and causes of turn down. So with that, thank you for your attention.
Thank you very much, Dr. Chan. And next step will be to remove the components, and we go back to Dr. Rajkumar Thangaraj from Highland, Scotland, who will take us through the techniques of component removal.
Thank you. Just sharing my screen. Right. This is a second talk. So moving on to how to remove difficult components. So I have my talk in 4 points, key points, my tools, how I do it, and learning points. The key is not to be in a rush. I'm happy with Nicolaas and what Lou said is the key is not to be in a rush, because it's very easy to break a femur or the tibia and you're in a difficult position. Exposure should be adequate, soft tissue release and the contracture release, and most importantly, make sure that you take the deep samples and use at least 5 samples and separate clean forceps and a knife to remove the membrane behind the components for testing for both the histology and microbiology. The key points is try avoiding. When I say saw, what I meant is like a high speed saw beneath the components, because it can cause thermal necrosis and bone damage, and we'd like to reconstruct the bone as much as possible. So I use very fine and narrow osteotomes and a small mallet, so that not to give too much of hitting force, as the bone is viscoelastic. And then, as Nicolaas has said, we need to have specific tools for removal of the poly, and as always try to know what are the components there before, what are the weaknesses, and how to remove them from the companies that they make it. And most importantly, our technique should preserve the bone at any cost. So my tools are, this is my poly disengagement tool. So I try to not to hit the poly, try to remove it with a certain disengagement tool, and the osteotomes, various osteotomes. And again, sometimes we do use a giggly saw, but not a power saw beneath the components. And again, no heavy hitting, and bone is viscoelastic. I'm reiterating those facts. For removal of the femoral components, I use the femoral slot hammers. Once I use the osteotomes behind the component to loosen any bone in cement interface, I use a slot hammer to remove it. And then I have some cement removal, certain sebotomes and some Grace osteotomes, which are commercially available. They're very thin, which goes very well beneath the tibial tray and behind the femoral component. And if in certain times, if the tibial component can take a slot hammer, I use that. And then the curettes. Once the components are removed, if I have a big cement bleb on the femur or over the tibia, I have Oscar instruments. And then once everything comes off, I use a bony burr to delineate the defects. Unfortunately, I don't use any robots or navigations during this removal of the components. As an example of how I do it, an example is a recent revision. This is a patient who had a yearly failure. Aspiration was negative, but the knee, as expected, was unstable. So after a double prep and a pre-wash, I aspirate it always. And I try to use as much as previous care as possible. And depends on approach, as Lewis and Nicolaas has explained, either extensile femoral approach. And the patellar tendon, as explained earlier, a little bit of banana peeling is always common, but a complete rupture is not. Once that is done, I use the tool to disengage the poly. And once the poly is disengaged, I use any osteotomes or anything to just lever it out. It serves two purposes: to check whether the poly was worn out and the knot has been damaged when you're trying to remove it out. Yeah. When you're doing the femoral components, again, take time, use osteotomes, and then I use a slot hammer and preserve the bone and try to prevent the condyles, as these condyles are very porotic at that moment and it's easy to break. In this particular case, as you can see, the component was very loose and it came very easily. For the tibial component removal, the key is to actually sublux the tibia fully with the tibial retractor and ensure that the tibial component is cleared of the posterolateral femoral condyle, because very often when you're trying to take it out, it's a posterolateral femoral condyle gets caught up and you can crack that corner. And I used various osteotomes to establish the implant bone interface, and then use various sharp and narrow osteotomes. Once I've gone through it, I use a curved osteotome to just gently lever it off. I have this video to share. This is the well-fixed tibial component. So I use a broad osteotome to find the interface to start with. And as you can see, I use a toffee mallet. I don't use a big mallet to preserve the bone and to prevent any fracture. And then once I use a Grace osteotome, which is a very fine osteotomes, to just gently chisel off the component gently, and they keep the proximal tibia intact. And as you can see, I'm keeping the femur off the tibia completely. And once that's loose, I use the osteotome gently and slowly and steadily turn it around, and then I sublux the femur back so that it doesn't caught up in the corner, and you can see that the component comes easily. But then the real surgery starts after this, just for completion purpose of this case. You can see how bad the knee was to start with, and by the time you do the debridement, you can see the defects. I use the curettes to take out all the membranes behind the defect. And then once I use sharp knives, multiple curettes, and then the bony burrs to get into the bone bleeding. And once I define the defect, then I put the trials with and then check the stability. And then finally, once I'm happy, I use the cones predominantly for reconstructing any major defects. And then I implant the real, I do two stages when I cement separately both the tibia and femur separately. And that's the final picture. And the learning points are: do not be in a rush. When I say thaw, not to cause thermal necrosis to the bone, use osteotomes and preserve bone. But then the debridement is a key. It often takes more time than the actual procedure, actual removal of the components or insertion of the revision TKR. Thank you.
Thank you, Raj. That was a very eloquent presentation on component removals and great take-home message. We're coming to the sort of business end of this symposium, and Radian Morgan-Jones made a great contribution to fixation in the revision scenario, speaking about the zonal fixation. It's my great pleasure to invite Dr. Orfan Arafah to talk to us about this concept.
Thank you so much, Dr. Sufyan and Mujib. And I'd like to apologize for the technical difficulties in my Zoom application. Do you see the screen from my?
Yes, we do.
Okay, so I tried to upload my PowerPoint through the phone. It failed, so I went to plan C. I think this is the easiest way to take a camera to my laptop screen. So I would be honored to present this topic. As we all know, the revision total knee arthroplasty is going to be 6 times higher if we compare the rate in 2005 and 2030. So we're going to experience a whole lot of a revision for the next 6 years. I'll take this case. It's a 72-year-old female who came to the emergency with a severe pain after a fall from a wet floor in the bathroom. And as you can see on the x-ray, she's an obese patient with significant bone loss and loosening of the tibial component. So whenever I look at any revision rate or any revision case, first I will go through the understanding the mechanism of failure, and then plan for removal of a well-fixed implant. Managing bone loss is going to be the last talk by my colleague, Rajpal. The soft tissue balancing, and then at the end, how to obtain a stable fixation to achieve proper placement of the prosthesis, limb alignment, and restore the joint line. So we've had a brief teaching about the zonal fixation by Faris Haddad in his paper in 2015, and he divided the zones of the femur and the tibia into 3 zones. Zone 1 is the epiphysis, zone 2 metaphysis, and zone 3 is the diaphysis. And his paper here recommended achieving 2 zones of 3 zones whenever you're doing revision total knee arthroplasty. So Traditionally, we were aiming for zone 1, which is the metaphysis, diaphysis and the epiphysis, and then ignoring the zone 2, which is a significant, providing a good fixation in a revision arthroplasty, and played an important role to achieve a good fixation. So for zone 1, it's compromised with all implant failure, whether you're going to have an implant removed with the bone at the back of the implant. Even if you're lucky to remove the implant without any cement on it, you're going to have difficulties removing the cement from the bone. And this is one of my cases. And this is after removing the cement from the bone, you're going to end up with a significant bone loss in zone 1 in both tibia and the femur. So for zone 1, if it's contained within 5 to 10 millimeter, you can fill this gap with the cement. If it's an ORI type 1 or type 2A, affecting the less than 50% of the tibial plateau or femoral condyle, you can add the screws to augment the cement. And this technique has shown significant success rate if you treat this uncontained defect with the screw, as you can see on this case, with the cement underneath the tibial implant. Even this technique in obese patients showed a significant higher outcome for maintaining the implant longevity, preventing the area loosening. Other modalities to restore zone 1 is the impaction bone grafting, and this usually is being reserved for the young patient and the patient with the significant bone loss in zone 1. So for the key for this one is not to impact the bone very hard, to keep some porosities, and not to make it very loose so you can achieve a strong fixation. The disadvantage of this technique is the late resorption of the bone graft, fracture, and non-union, which is very high in this situation. The latest modality for zone 1 restoration is the augment or the half block augment that comes on both right and left, medial and lateral, and we have as well the half block that will span both medial and lateral side. In zone 3, which is the stem, this is very crucial for the obtaining an implant fixation. Yeah, usually the stem is a cobalt chrome in a cemented, or titanium in an uncemented stem, and there was agreed stress shielding.
I think he. Okay, go ahead, Dr.
I'm back.
Yeah, okay.
Sorry, Majib. So the titanium showed the less stress shielding compared to the cobalt chrome stem. What about the diameter? There is something called the CFR, which is the canal filling ratio, and you have to achieve at least more than 85 CFR to obtain a good fixation and to prevent area loosening when you rely on a zone 3 fixation. What about the length of the stem? If you go short on the stem, you will have a problem with the improper axial loading, and if you go very long, you're going to have a problem with the stress shielding, as you can see on this case. So the proper length, traditionally, it's about 4 centimeters of a diaphysial engagement, and it depends as well on the geometry of the tibia or the femur. So if you have a straight tibia or femur, you can go a longer stem. But if you have a bowed tibia or a femur, be careful that the stem might deviate your component into a posterior medial and a valgus position. A lot of literature comparing the cemented and the press fit, and this is a big randomized controlled trial that controlled the both group for the same construct with the same length, cemented or press fit, the same ORI bone defect classification, the same implant constraint, and they've excluded the re-revision total knee arthroplasty, and there was no difference reported between the zone 3 fixation, whether you're using a press fit or a cemented an implant. But the problem with the stem that you have difficulties, as you mentioned, with the bowed medullary canal or a pituitous distal canal, that you have difficulty obtaining a good fixation. And if the canal is tight, you're going to have a problem with the stem pain, especially on the tibial side. And that's why we are achieving more and more nowadays a zone 2 fixation with the metaphysial engagement using either a cone or a sleeve. So the cone comes independent; it will achieve only restoration of the bone defect, while the sleeve will achieve both restoration and augmentation of the implant. Different companies providing different cones and sleeve. Usually failure to utilize the zone 2 fixation will lead to uncontrolled biomechanical shear, stress shielding on the epiphysis, leading to an early failure of the implant, as you can see on this case. And this is a case where the patient had a stress shielding, and this was managed with the zone 2 fixation, augmenting this implant with the sleeve. The sleeve has a simplified surgical technique. It's like a hip. It's a re-approach, and then you cut. It's a very time efficient. You can, on the tibial side, you can align the tip of the sleeve toward the joint line, and you can build your implant accordingly. On the femur, you have to be very careful. The sleeve has to be sunk in, and the joint line is marked on the implant. So you have to sink your implant deep into the femur to achieve a proper joint line. Otherwise, you're going to break the distal femur if you try to impact this very hardly. And this is a video showing the sleeve on the tibial side, as if you are doing a hip uncemented stem. You just approach frame and then you place your implant. And this on this side, you can see the implant showing the zone 1 fixation, which is the epiphysis, medial half block with the zone 2 sleeve, and zone 3 the stem. So I usually, when I do my revision, I rely on the 3 zones: zone 1, zone 2, and zone 3. Back to this case, this lady had a significant bone loss, and we decided to go with the cone instead of the sleeve. And you can see third of the tibial plateau has been disrupted, and then the patient is going to rely only on the posterior and posterior lateral part of her tibia. And this is the trial of the cones from Zimmer. And this is the how you want to see it. You want to be able to hold the whole implant, lifting the leg up without disengaging the cone from the tibial tray. And this is the final X-ray. Other advantage of the sleeve on the femur side, that you can ignore the deformity, and you can close your flexion gap if you tilt your sleeve posteriorly, and this will achieve a good mechanical support and balancing of extension and the flexion gap. The tibial bowing, that you have a problem with the tibial sleeve, can be overcome with the tibial zone 2 fixation. So the what is the survivorship? It has a good survivorship, up to 92% on the tibial side over 5 years, and 90% survivorship on the femoral side if you're going to use a zone 2 fixation. A lot of data showing a good result that will support using a zone 2 with a sleeve or a cones. And this is the Kaplan-Meier survivorship showing a good survivorship of the implant. So the learning point of the zone 2 fixation, it has a good implant fixation to restore both rotation and axial stability. It allows for better control of a cutting block and implant position, provide the fixation closer to the joint line. It allows management of the severe bone defect, and provide the rigid fixation of with the porous surface. Thank you so much.
Thank you very much, Dr. Arafah. And we'll move to the last but not least, the last presentation of this webinar is none other than Dr. Ashok Rajgopal, who, as Dr. VIKAS KHANDUJA said, needs no introduction, well-known figure all over the world, designer of multiple knee systems, and well-written and published author with multiple textbook and articles. So he'll be talking to us about management of bone defect and revision total knee arthroplasty. Go ahead, Doc.
Thank you, Mujib. Right. So we've had some very eloquent presentations, and my brief is to talk about managing major bone loss and revision total knee arthroplasty. I have no conflict of interest. So a large volume of primary knee replacements are done across the world. The revision load is correspondingly huge. You saw some very elegant ways of removing implants, but consequent to osteolysis and stress fractures, there's frequent indications where there's considerable bone loss, and methods of knee and bone augmentation are really quite crucial. So I think as with anything else, bone loss management is a stepwise algorithm. You need to do a preoperative planning, assessing instability. And I think cannot overemphasize the fact that instability may be a consequence of either a ligamentous incompetence or a bony loss, and the management is significantly different. So you also need to assess the extent and location of the bone loss. CT scans can come helpful in some of these situations. You need to assess the need for augment stems and graft complexes, and have a complete complement of both implants constrained options, and hinges. This is the most frequent classification. There are several of these available, but for ease of description, ARI is really the one that we follow, and I think a large segment of the revision surgeons follow this, both on the femoral side and on the tibial side. So there are multiple options that are available even in large defects, particularly if they are localized methacrylate cement augmentation alone or with screws, grafting augments in terms of metal wedges, bulk allografts, TM cones and sleeves, and you just heard a very elegant presentation on this. And it's mandatory to explain that each time you use augments and allografts, intramedullary stem is used primarily to stabilize your construct. And this is particularly in place when constrained options are or large grafts are required. One of the game changers in revision knee arthroplasty has been the availability and advent of metal cones and sleeves. Tibial and femoral trabecular metal cones are a unique solution because they substitute for bone loss, improve metaphyseal fixation, particularly in zone 2. They help to correct malalignment, restore the joint line, and certainly there is now sufficient evidence of biointegration. And there is some evidence that these may be a barrier to infection. So our indications, and we primarily use TM cones, we do not use sleeves, we have little or no experience with this. So our indications for the TM cone have been large defects in revision situations. Certainly most of us who work in this part of the world know that even in primary situations, sometimes you get very, very neglected clinical presentations with massive bone loss that oftentimes may need the use of cones. Periprosthetic fractures, and you heard a very elegant presentation of causes of failure. And sometimes you have to use these. And of course, we have interest in tumors in the metaphyseal region of the femur and tibia, where we've had some extensive experience with the TM cone. So the philosophy is that it achieves stability in the proximal tibia and the distal femur, allowing for compressive forces to gravitate towards the surrounding bone, reinforces the endosteal canal, allows for stem insertion and canal for a femur and tibial fit. And the real issue here is that you need to prepare the defect to accept these cones. The fact that it is a free-floating device allows for alignment of the intramedullary stem to get alignment from the in terms of aligning the implant. So the trabecular metal technology is really a macro structure reticulated vitreous carbon with tantalum through chemical vaporization with 10 times greater strength. It has excellent porosity and modulus elasticity, which is similar to cancellous bone, and a compressive strength, very similar to bone. It facilitates rapid ingrowth, is bioactive, and facilitates rapid ingrowth of vascularized tissue to its porous surface. It is extremely porous, osteoconductive, provides fixation ductility with a high intrinsic friction, thereby ensuring very early inherent stability, and it's one of the most biocompatible materials. By approximating the mechanical and physical property, this material enables rapid and extensive bone infiltration. And lab studies have indicated that bone ingrowth is 42% at 4 weeks and almost 80% at 1 year. And the modulus of elasticity of the TM material is that between that of the cortical and the cancellous bone. Some clinical applications that we have experienced in our practice: massive bone loss caused by osteolysis from a loose implant aseptic revision. And this is a way that we dealt with this particular clinical situation. You have to assess the size of the defect and its preparation for fit and contour using high-speed burr. The cone is used in a press fit, and any voids are filled with morcellated bone. Some clinical examples of patient with osteolysis secondary to infection, where we used a TM cone on the tibial side, And this patient went on to have good osseointegration and stable clinical situation. On the femoral side, again, femoral TM usage. This was secondary to a osteolysis, almost a 25 millimeter defect on the distal femur, where we used a TM cone. Like I said, in the primary situation, we oftentimes see patients like this, massive defects, which require a rotating hinge type of an option. The collaterals are gone. These are grossly unstable with massive bone losses. So though not commonly seen, we have had some experience with using the TM cone in these primaries. Periprosthetic fractures, and we described this in 2014 using stacked cones, and we described this in the Journal of Knee Surgery. This has been an excellent way of managing this very difficult problem. This is a 88-year-old lady who had a Miller-Galante 2 almost 20 years ago, met with a road traffic accident, a very frail lady. And we did this, and you can see excellent bone restitution at 14 months after the index surgery. We've also had experience of using TM cones in malignant tumors. This was one which we did. Patient had a recurrence at 6 years. We had the opportunity to go back and retrieve that specimen. There was evidence of extensive bone formation and osteointegration. Sometimes we do get these rather bizarre-looking implants which defy any definition or logic. These are local, indigenously manufactured with massive bone loss, which again we treated using these TM cones. If you look at the literature support, there's been overwhelming support that supports the use of TM cone. And as you go down the sort of timeline, several authors have alluded to the fact that you get great mechanical stability, biological reliability of the TM cones in revision total knee arthroplasties. More recent articles, overall infection rate of 7.38%, aseptic loosening revision only 1.3%, excellent survivorship at 10 years. We have published quite extensively on this subject. We had this publication in 2018 where we looked at our management of large defects with excellent outcomes. We looked at the stat cones, which I just described. This was in Journal of Knee Surgery in 2019. More recently, we did a midterm evaluation of a tantalum cones, and we published this in 2021. And most recently, along with Jan Victor and his group, we did a meta-analysis of comparison between sleeves and cones, and we did a systematic review and meta-analysis was published in 2021. In conclusion, managing major bone loss is critical to ensuring restoration of the joint line and ensuring stability. Porous material substitutes have offered a much-needed option in the management of this very difficult situation. The TM, by virtue of its resembling trabecular bone in cellular structure and weight-bearing characteristics, approximates the mechanical and physical properties of bone in intrinsically high friction, and this material enables for rapid and extensive bone infiltration. I'd like to thank you for your participation, ladies and gentlemen. I'd like to invite you to fill out our post-webinar survey and receive a personalized certificate of attendance. I'd like to hand it back to my co-moderator, Dr. Mujib, for the question and answer.
So thank you very much, all the presenters. Wonderful session, beautiful lecture, and fantastic cases with elegant presentation. Just to sum it up, I would like to share the key point that was taken from this session. So these were basically the summary points from each presentation. So this was from Dr. Rajkumar Thangaraj, the first presentation, which is the causes of knee failure, aseptic loosening, PGI and prosthetic fracture, periprosthetic fracture, young patients, high demand patients, and early revision are associated with high rate of revision, multiple factors, patient, surgeon, and implant. Preoperative planning talk from Dr. Nicolaas Budhiparama. Surgeon has to be familiar with the individual implant system, follow some classification system, which will help you to plan your surgery and individualize your treatment plan. Every patient is different and every failed knee is different. This is summary slide from Dr. Louis Chan about different surgical exposure. Pay attention to the blood supply, extensile approaches, rectus snip, medial parapatellar arthrotomy, and finally that banana peel that he touched on this last slide. Component removal talk by Dr. Rajkumar again. Avoid saw, use osteotome, and have specific instrumentation if you can. Try to preserve as much as you can in bone, and also the key point is extensive debridement, which might take more time. Be careful, avoid any bone fracture. This is from Dr. Orfan Arafah's talk about zone 2 fixation, which is the new kid on the block, and has some advantages like enhancing rotation, axial stability, better control of cutting block and implant position, enhanced fixation, allows management of bone defect, and provides rigid fixation. And this is from Dr. Rajgopal. Managing bone loss is critical to ensure the restoration of joint line and stability. TM resembles trabecular bone, and it's as close possible material in terms of mechanical and physical properties to bone, has got a wonderful high friction, and has superb osseointegration, and has proved in multiple literature to be a wonderful material when you're looking into managing bone defect and revision total knee arthroplasty. So there's a question, Dr. Rajgopal from the audience, asking, do you think that the stacked cone technique would provide longer survival than modular or tumor prosthesis and severe bone loss, especially when you have this thing on the femoral side?
Thank you for that question, Mojib. I think it's a great question. We did this primarily with a thought that with stacked cones, the amount of osteogenic osteointegration that happens was really quite phenomenally good. The chance of doing a distal femoral resection also did occur to us. The only challenge being that in these difficult situations, if for whatever reason that distal femoral implant fails, the only salvage option to go back to is an amputation. So we have now done a total of almost 34 of these, and we have just submitted our article for publication. It's just been accepted. So at almost 11 years, we have had one failure from aseptic loosening in a very, very obese patient, but in all the others, it is done really very well. So certainly I would sort of concede the fact that distal femoral replacement is an available option, but because of the fear of reading a massive salvage procedure in the event that it fails, we prefer to do this and have that one more thing at the back of our mind that we can still go back to a distal femoral replacement.
Oh, perfect. Okay. I didn't get any more questions. And before we end this session, I'd like to bring to attention of our audience that we do have a part 2 of this Revision Total Knee webinar series, which will be broadcasted next week at the same time. And we also have another webinar, which is personalized knee alignment, that will be broadcasted on 31st of May, Friday, 12 to 13 Central European Time. And there's another webinar on 7th of June, which is same time on Friday, 12 to 1 p.m. Central European Time. It's titled as Painful Knee Joint. I would like to welcome you all to our 44th SICOT Orthopedic World Congress in Belgrade. You have this website to register and get more information if you're interested. So thank you very much, and we'll bring this webinar to end.
Thank you, Mojib, and thanks to all the speakers. Thank you, Sufyan, for facilitating this wonderful webinar, and look forward to having the team back a week from now for the round 2 of the revision. Thank you all very much.
Thank you. Thank you to meet everyone. Thank you.
Thank you so much. It was a pleasure to be with you all.